Hi, my name is Dr. Stephanie Tran, and I'm a practicing endodontist in New York City. In this video series, I'll be walking you through some common challenges and indications I've encountered in the field, and how I've used CBCT to help me problem solve and treatment plan more quickly and efficiently, and how it can help you too. In today's video, I'm going to be discussing how CBCT is a great tool for diagnosis and treatment planning for evaluation of resorption defects in teeth. Today, we're going to be discussing what are some of the key indicators in 2D X-rays and 3D CBCT scans for resorption defects. We're going to be discussing what are these defects and how involved they may be and whether or not they can be treated. And we're going to evaluate what those findings are that allow us to know whether or not those resorption defects can be treated, and that's using CBCT. So specifically, what is a resorption defect? We're going to be discussing the one specific type, which is external cervical invasive resorption, ECIR. You may also see it in other literature as ECR. It's the loss of dental hard tissue as the result of odontoclastic action. Basically, it's kind of like the body is resorbing at itself. This is how I explain it to patients. Unfortunately, that the patient's body is having an inflammatory reaction at the tooth itself. The way that inflammatory reaction happens is with the odontoclasts. Those are the same types of cells that are involved in like periodontal inflammation and other inflammation into the tooth. In this case, the ECIR resorption defects usually start off in the cervical region on the root surface of the teeth. Now, Say has published in 1999 and following subsequent papers that there is a certain classification system. So basically how big the resorption defect is. For ECIR, it will often spread circumferentially, so buccolingually, mesial distally, and also apical coronally, and so it will spread throughout the tooth. However, it often does not necessarily spread into the pulp, and that's because the root canal is surrounded by a protective layer referred to as the pericanalar resorption resistant sheet. So what we'll see is often in the CT or the 2D X-ray, you'll see the resorption around the canal system, but you'll see very specific lines around the canal that show that that resorption had not gotten into the canal itself. So what does it look like? ECIR can present itself in the different variations of the classification system. It may be a very localized defect. So for example, in this case, it's a very localized radiolucency. It looks almost like caries, even though it's actually not a carious lesion, but it may show up as a radiolucency on a two-dimensional radiograph that looks a lot like it. Now, in this case, this is a Say class 1. You can definitely check out my other videos about resorption defects and how to treat them in my following videos. So definitely check out Schein for more information. In this case, I'm not going to be discussing this specific patient because this was one that I was able to treat. But we can see if it's a very small defect, so a Say class 1, it can definitely be treated. However, what happens when the lesion may be a little bit larger? So in this case, this patient had presented to me with a great example of ECIR, and we can definitely see in the following CT how we evaluated it and what it can look like and how we diagnose it. So specifically, this patient had been referred by their restorative dentist for evaluation for possible root canal treatment. The reason for it was very large carious lesion on the mesial portion of the upper second molar. However, this patient had reported they didn't have any pain, they didn't have any symptoms, and not any swelling either. We noted from the clinical findings that this tooth had a large mesial caries that was very close to the pulp, and there was some odd radiolucency in the cervical area on the distal portion of the tooth. That right there is a red flag as to what might be going on with this tooth. We can see in this 2D radiograph that The canal system is pretty obvious on the two-dimensional radiograph for all the canals, but for that second molar, we can definitely see a very odd kind of moth-eaten, kind of uneven radiolucency right in the cervical area, a little bit on the distal of the pulp chamber. Additionally, remember we talked about that protective layer over the root canal system? We can see that very faint line around that pulp chamber that is consistent with that sheet, that protective sheet that we were talking about, and why the resorption defect doesn't necessarily go into the pulp itself. So when I saw that very kind of fuzzy, kind of moth-eaten look right in that cervical area of the tooth, that was a red flag for me that I was suspecting ECIR. And when we're suspecting that external cervical resorption, a CBCT is absolutely necessary. Now, we do still have to take the testing and evaluate the tooth. So this particular patient had some hypersensitivity to cold, but no lingering, and this patient, no severe lingering, and this patient also had no percussion and palpation tenderness. So for her, unfortunately, she didn't have very many symptoms. However, the CBCT tells another story. So we can see from these screenshots of the CT that tooth had all the hallmark findings of external cervical invasive resorption. You see the resorption defect coming right into the tooth, right at that cervical area, right around the CEJ. And we can see that it's very extensive all the way circumferentially around the canal system, as we had discussed. So it's extending even to the mesial portion of the tooth, the palatal root, and further. So let's take a look at the CT and see what the findings are in the CT that tell us more information about the resorption defect. Remember, if we suspect there is external cervical resorption or other resorption defects of a tooth, a CBCT is absolutely necessary. So in this case, we definitely want to then center everything on the tooth. Keep in mind that in endodontics, unlike surgical CBCTs, we actually have a very focused, targeted look at just the tooth in question. So we actually focus all the crosshairs on just the tooth or even just one root. We can see here that we can then start to scroll through the different slices. So in this case, I had centered this tooth on the crosshairs like that, okay? And then we can center it along the mesiobuccal and distal buccal roots like that. And again, center it on the root slightly like that. Okay, so we can see that for these buccal roots, we can see a lot of different interesting findings. This distal buccal root is extremely curved, so some fun anatomy evaluations. But most importantly, what about that resorption defect? So that resorption defect occurred right on the distal, just as we had discussed. We can turn off the crosshairs to better take a look at it. It starts in that distal cervical area. It invades the dentin all the way to the pulp, but stops right at that pulp sheath that we were talking about, so that we can see that protective layer right here. We can then see that protective layer even along the canals a little bit there, so it's not necessarily going into the canal system. Again, there's that protective layer. In the bottom cross-sectional view, we can see that as we look at the tooth further down, so we're now traveling apically down the tooth, we can see that that resorption defect had started in that cervical area here, is really extensive into the tooth here, and then travels down, unfortunately, the palatal root. So we can see here all that kind of moth-eaten fuzzy look. We can see that protective sheath. We can see the moth-eaten fuzzy radiolucencies. That tells me it's quite far down the palatal. In fact, it keeps going as I scroll down. It doesn't go away until approximately the mid-root apical, or close to the apical portion of the root. So we're now at this level before the resorption defect finally goes away. And then additionally, we can see from the other views that what that resorption defect looks like as well, how severe that resorption is as well. So when we center on the tooth right there, like that, we can see that that resorption had actually started on the distal here. And then as we're scrolling through, we can see that resorption spreading all through that, around the pulp chamber. So we can see all that resorption here. And that resorption extending pretty close to the bifurcation. Extends very deep into the palatal wall. So it's all the way down here, which means that by the time we remove it, all the way down to like there's not very much palatal root structure left. And that when there is that severe kind of extension of the resorption, that means that it's a little bit too extensive. So by the time we remove that resorption defect here on the lingual, we're extending all the way into almost the furcation areas and very deep into the tooth like that. For example, we talked about that palatal there, and now we center it. It's extending very far down that palatal root, all the way to that mid-root portion. And we can see it's surrounding much of that pulp chamber and extending throughout the palatal root as well. Here's again, little signs of that protective sheath, again confirming that this is invasive cervical resorption and how extensive it is. So because of this finding that the resorption defect extended to basically to the mid-root portion of the tooth, we're looking at a Hithersae class 3, and that the treatment of this tooth is highly guarded with the prognosis, because by the time we remove all of the resorption, so the way we treat external cervical resorption is that we have to remove the resorption, just like when we have to remove inflammation due to periodontal disease. You have to remove most of that inflammation. That inflammatory process, though, is so extensive that by the time we remove it, there's very, very, very little tooth structure left. And so because there's so little tooth structure left and it's so deep down the tooth that's often unable to be accessed, treatment of this tooth was not recommended necessarily. And instead, the tooth was recommended either for an extraction if the tooth became severely symptomatic, or unfortunately, this was not a tooth that we could just watch very easily because this patient had that large caries on the mesial. That's another issue in this case. We can see that extensive mesial caries and how it's very close to the pulp horn. In this case, the patient could possibly consider a restoration, a direct restoration, but the patient understood that there was a very high risk of the pulp developing irreversible pulpitis after attempts at treatment. So because of that, the patient was recommended to return to their restorative dentist for further evaluation of either possibly restoring and then watching the external cervical resorption defect. Sometimes these things can just be maintained. It depends on if it's symptomatic and how involved it is, and there are many, many factors. So in this particular case, I'd say it depends. However, sometimes the resorption can just kind of stay inert, and you can just watch it over time in some instances. However, if it's very extensive, we would then have to recommend an extraction. So as we can see, CBCT is so helpful to further evaluate external cervical resorption defects and for better diagnosis and treatment planning of these lesions. Well, as you can see, technology can be a game changer when it comes to improved diagnostics and treatment planning. And I hope this video provided some useful tips and techniques that you can start implementing in your practice today. If you found this content useful, don't forget to hit the subscribe button and the bell icon to be alerted of all future videos. Thank you.